what are the rapid tests, what are rapid tests rather, and why are they needed? And second, how do these tests work? And karugtong niyan, what evidence is there for these tests that they actually work? So when I was looking through the literature, what I actually found was a lot of reference to what we call point-of-care tests. And the definition seems very self-evident, no? Very straightforward. It's a medical diagnostic test performed outside of the clinical laboratory at the point of care. So halos katabi na ng pasyente in close proximity to where the patient is receiving care. And because it is outside of the laboratory, then we can expect that it will be typically performed by somebody who is not a lab technician, not a medical technician, and the results are useful or immediately used rather for clinical decision making. Now, you will also see references in the infectious disease literature of point-of-care tests being synonymous with rapid diagnostic tests. And since we are at PIDSP, I chose to focus on rapid diagnostics or point-of-care tests that are utilized in infectious disease. Now, there are very many despite the many different definitions, I think what they have in common is that first, there is a need for rapid turnaround of these tests, and there should be communication of the results to guide clinical decisions. And secondly, the completion of the testing and the follow-up action occur in the same clinical encounter, so during one clinic visit. Now, I mentioned that there are very many different definitions around, and I think one of the reasons for this is that your target profile is quite diverse. No? The population or the group that you want to serve are very different. First, you have home-based tests that might be relevant. Like for example, if any of you have ever used a pregnancy test, then you will know that you have different requirements with respect to ease of use and rapidity of results. If you were going to use that test in a community, then you would need, for example, a different degree of accuracy, considering that for the infectious disease tests that are employed, they're usually covering diseases like malaria, HIV, or dengue. In the same way, if you have a user who is either in the clinic or the healthcare or the health center, you probably have a healthcare worker there, then you will have different requirements for these tests and so on down the line. So, the bottom line is, why are POCTs or point-of-care tests needed in the first place? Well, we are in a resource-limited setting. We know that we would have always appreciated guidance when we're faced with a febrile child who's coughing. I received a call late last night from one of our more senior consultants, and I was quite surprised why he would be calling me at 10 in the evening. So, ang sabi daw po niya, yung apo kasi niya may sakit. And he was telling me the history. May fever daw po nung weekend, nagkaroon din ng lagnat nung Lunes, pero by Tuesday, pumasok na. Nung kinagabihan, nilalagnat. So the usual questions, we went through the usual questions in the history, basically trying to determine whether there was a focus of infection. And unfortunately, there wasn't anything very obvious. And so what we ended up agreeing to do is actually some diagnostic testing for dengue, no? So I would have appreciated, I'm sure, and I'm sure he would have appreciated something that would give him the answer right at that point, no? Because if something that was quick and easy to perform and required little or no additional equipment was available, then that would be quite helpful. If it could be performed by healthcare professionals other than a pathology laboratory staff, no? Because sometimes we are in a setting where that's not even available. If it can be designed for use either with individual or a limited number of samples to make them more economical, and if it was possible to store it within room temperature for a fairly extended period of time, then that would also be ideal. Now, there could also be its usefulness in special situations, like for example in outbreaks where a result is required for patient management and infection control. I can imagine the more recent report a couple of months back of a patient with suspected MERS-CoV who consulted in one of the private hospitals in Manila. If you were keeping up with the news, you would have heard about it, and it actually caused quite a bit of a stir in their emergency room. I'm sure they would have appreciated being able to test that patient right away for MERS-CoV so that they could determine what to do next in that setting. Or maybe if you were in an outpatient setting and you were managing a tricky disease, like maybe a sexually transmitted infection, where the patient might not necessarily come back, then you would also have appreciated the point-of-care test. Now, having established that it is useful, there is a need for it, what are the commonly available point-of-care tests that can now be accessed in the market? There are actually 5 distinct categories. And when we look at point-of-care tests, we basically just have to try to remember these categories so we can understand where they are located and understand how they work. So there are antigen detection tests, there are molecular detection tests, there are also rapid biochemical tests, direct microscopy of specimen, and finally serologic testing. Now, we are quite familiar with number 3 and number 4 because we do use dipstick tests in our clinical practice, although most of the time this is still located in the laboratory setting. But there's actually nothing to stop us from keeping these dipsticks inside our clinic to have them handy for testing and correlation with the patient's clinical status. And of course, we should be very familiar with direct microscopy, and we should be utilizing these tests more optimally and asking for a return of result for gram stain or an AFP smear within the allowable limits. I'm sure we all remember from med school how fast it was actually, or how quickly it actually takes to get a gram stain result back. So a laboratory has no business telling us that it should take another 24 or 48 hours for a gram stain to be released. So what is left for me now to discuss are our antigen detection tests / antibody detection tests. So that's number 1 and number 5, and molecular detection tests utilizing nucleic acid probes. And so for the next few slides, I'd just like to show you some diagrams to familiarize you with the test principles so that if somebody comes along offering us these tests, then we can understand where they're coming from and decide whether these tests are useful in our clinical practice. So the most common format of a point-of-care test is actually an antigen or antibody capture method using a lateral flow immunochromatographic test system. So it's quite a mouthful. So let's try to focus first on an immunochromatographic test. Chroma, color, immuno, meaning we're looking for either the antigen or the antibody. You want it to flow through a capture device and cause a color change. So that's basically what it is in different shapes and sizes. So in this diagram, you drop your sample here, and as it flows, it interacts with some biomarkers, and these biomarkers are captured to either produce a negative or a positive result. So quite a simple concept, and the challenge is actually to develop the test substances, either the antibody or the antigen, in a sufficiently purified state so that you can get very sensitive and specific results. So some examples of lateral flow immunoassay tests that are already available in the market, more often than not in Western countries, are these tests for group A strep, where all you need to do is to get a throat swab, moisten it in a test reagent, stick it into a well, and wait for a positive or a negative result to develop after you introduce your reagent in as little as 5 minutes. So it sounds amazing, and it actually was available for commercial use quite a number of years ago, but I don't think it took off. No, not this exact similar format, but it was available several years ago. However, the test, I understand, was quite prohibitive in comparison to just giving the patient a course of antibiotics. This is another test format now for infectious mononucleosis. basically utilizing the same test format where you have a membrane captured or sandwiched in a plastic wafer, where you now add whole blood, which diffuses through the cellulose strip and produces a positive or a negative result, much like the usual pregnancy tests that we use at home. There are also dipstick assays, this time now for RSV. I'd just like you to focus on the diagrams where you have a swab that is dipped into a reagent tube and a dipstick follows, which captures or tries to capture the antigen that is found in the processed reagent. And again, in about 15 minutes or so, you get a result. There is also such a thing as a dipstick test for malaria, which has been used in field studies and has performed quite well in comparison to microscopy. And in this particular test type, you can actually determine the kind or the species of Plasmodium that is being, or that the patient actually has. The second test format that I mentioned that I was going to talk more about was actually nucleic acid amplification. So basically a PCR test. What are PCR tests? You want to cause a sufficient amount of your nucleic acid to be available in the test material so that it becomes possible to detect its presence. And naturally, because we are now looking for microbial nucleic acids, then these tests provide a greater sensitivity and specificity than microbiological assays, or rather immunological assays, because even with very, very small amounts of the antigen, then you should be able to pick up its presence. However, up until the recent past, the problem with these PCRs were that they actually required a lot of machinery and required a very specialized degree of skill to be able to handle the specimens, process the specimens, and finally get or interpret the results. This is just an example of the gene expert system that we're all quite familiar with now. I'm sure most of us have already had occasion to request a gene expert TB test for INH or RIF sensitivity, and this is what it actually looks like in the laboratory. It's about this big, so it sits on a countertop. It has several wells into which you should put a cartridge. Now, in fact, the cartridges have different, or can process different test reagents. There's a gene expert series for Neisseria, for chlamydia, for MRSA, if I'm not mistaken, but we're quite familiar now with the TB testing. Now, after you process your reagent and insert it into the well, you just have to run the cartridge and you spew out the result. And so it's actually quite foolproof and doesn't really require that the technician have very specialized knowledge with respect to PCR technique. But what is now current is something this small. I'm not sure what iPhone this is. It looks like a 4. It doesn't even look like a 6. And the dimensions are just supposed to be 23 centimeters, about 9 inches, smaller than a ruler, and about a kilo. No? And so that's really tiny. It can sit on your tabletop. And with this kind of point-of-care test, then you can actually do a lot of things within your clinic with just a specimen that you can obtain from your patient very easily. It is also battery operated, it's wireless and web enabled. No? So I hope to be able to put one in our section sometime soon. The release didn't say how much this costs. I'm sure it's very, very, very expensive. Now those tests, those nucleic acid amplification tests or NAATs, still require a machine. But if you look at the literature now, there are also other tests that are just in a cartridge format. All you have to do is to add your sample to the card, and all of the functions are performed. DNA extraction, PCR amplification, and detection of the target after exposure to some voltage applied to a carbon electrode. So there's another variation of this test. It's called the microwave amplified metal enhanced fluorescence. And so their basic principle is using microwave technology or microwave energy. You basically get metal to fuse to the nucleic acid, and it serves as a probe because there is a fluorescent tag on the metal. So something similar to this. Now, I was thinking, aren't we always cautioned to avoid putting metal substances into our commercial microwaves at home? So I presume they're using another kind of microwave technology and not like the one that we can imagine, no? But I guess the point of me sharing this with you is that now it is becoming increasingly possible to do nucleic acid amplification tests, or basically PCRs, even without the use of a machine. Now, what is in the market? I took this from a report that was made for the US military, and they're quite interested in having point-of-care tests because, of course, they do deploy their forces in a lot of developing countries, and when these personnel become sick, they want to make sure that they're able to diagnose and treat right away because of the risk of bioterrorism. And so they say that currently the number of infectious disease POC, or point-of-care tests that are available and approved in the US, is quite limited. Now, why is that? Granted, the technology that is now available, there is such a thing as a CLIA, C-L-I-A, or Clinical Laboratory Improvement Accreditation waiver that they have to get before they even run these point-of-care tests. What's the point of that waiver? It's supposed to ensure that the quality of the tests that are released in the market are actually sufficiently sensitive and specific so that whatever test result you get has some kind of a meaning for the patient. And so what are the tests that are now cleared by the US FDA? They have tests that are cleared for HIV, hepatitis C, flu RSV, EBV group A strep, adenovirus, H. pylori, trichomoniasis, and bacterial vaginosis, lastly Borrelia. So some of these are still also relevant in our setting, but of course we don't have the tick-borne diseases. So this looks quite busy, but I just like to show you basically that all of these tests are the ones that are FDA approved for infectious diseases in the US setting. Another very busy slide, but I just like to show you this column. Of the different point-of-care tests, I mentioned to you that we have two main categories, and you will see that almost all of them are immunochromatographic tests with only a couple of PCRs. And you will notice also that only the PCRs have good sensitivity, with the exception of the HIV rapid test, which although it is an ICT or an immunochromatographic test, is also quite sensitive at 99 to 100%. So basically, unless you use a nucleic acid-based test or a PCR test, your lower bound for sensitivity can range from anywhere from 50s to the 80s to a high 90%. Now, what is necessary for the developing countries? This table shows us some unmet needs for point-of-care tests in the developing world. If you will look at these syndromes, the current diagnostic test that we use for acute lower respiratory infections in the developing country setting is to use syndromic management using the IMCI. For febrile illness in children who are living in a malaria endemic area, there is a presumptive treatment for this condition. When you have STIs, again, your approach is syndromic, and you try to do point-of-care tests for some high-risk conditions like HIV and syphilis. Malaria and tuberculosis, there are only rapid antigen detection tests for malaria but none for tuberculosis. And for these other more exotic diseases, again, no POC tests exist. Now, as I end and try to discuss with you how, or rather, whether these tests work, I just like to share three reviews that looked specifically at rapid tests or point-of-care tests. This first one has already been discussed by Dr. Arshaga, so it makes my work easier. And I'd just like to highlight that in this review, looking at 6 studies, which was current through January of 2014, what they used as a point-of-care test was actually C-reactive proteins. So very different from all of the advanced stuff that I was discussing with you a while ago. No? So the only test that was consistently available for all of these studies was the C-reactive protein. And based on their results, their conclusion was that there was a likely, they could likely achieve a reduction in antibiotic use without any evidence for longer time to recovery, longer duration of ARI, lower level of patient satisfaction, or increased number of reconsults. But they needed a more precise effect estimate to assess the cost of intervention and compare the use of another POC biomarker to other antibiotic-saving strategies. Because in the end, this really is a question of whether the point-of-care test is going to be cost-effective in the management of patients, our patients with common infections. Another study looked at rapid viral diagnostics for febrile ARI in children at the emergency department. So again, a very familiar scenario. We have a young child with fever, with respiratory infections, basically the same as the story I shared with you a while ago, and we're trying to decide whether this patient should receive an antibiotic or whether this patient should actually go through several tests. And so the review focused on studies retrievable as of July 2014 and included 759 participants and tried to look at whether the use of a rapid viral detection test could change patient management and resource use with respect to antibiotic use, ancillary testing, and the length of emergency department visits. What did they see? Even if you had rapid viral tests, there was no, the trend towards decreased antibiotic use was seen, but it was not statistically significant. There were, though, lower rates of chest radiography being requested, but there was no effect on length of emergency department visits, blood testing, or urine testing. So it seems that as of this point, clinician reliance on viral testing in the emergency department, at least in the setting where this was performed, has still not reached the point where it can be recommended for routine use. And finally, let me share with you this review on the effect of rapid tests on malaria diagnosis. What this review focused on was to evaluate whether introducing rapid diagnostic tests in algorithms for the diagnosis and management of fever improves patient outcomes, reduces anti-malarial prescribing, and is safe compared to just using an algorithm for patient diagnosis. In this review, they were able to look at 17,500 patients who were participants in 7 trials. All of these patients either had fever or reported a history of fever. However, it is also important to note that in most of these trials, the algorithm users were either nurses or primary healthcare workers and not physicians. And as such, these results that I'm going to share with you might be easier to understand in that context. They said that rapid diagnostic tests supported diagnosis, had little or no effect on the number of participants remaining unwell. So if you use a rapid diagnostic test, it did not really make a difference whether the patient was how the patient was feeling 4 to 7 days after treatment was initiated. And using RDTs or rapid diagnostic tests to support your diagnosis did not have a consistent effect on the prescription of antibiotics. Thus, the recommendations included more training for the healthcare workers because they actually needed to understand these tests better and to adhere to the test results on a more consistent basis so that it could substantially reduce antimicrobial use. And in this setting where the studies were conducted, introducing rapid diagnostic tests did not seem to show any improvement in the health outcomes for the patients who participated. And so to end my talk, I just like to reemphasize that point-of-care tests conceptually have the potential to improve the management of infectious diseases, especially in resource-limited settings. But these have to fulfill the criteria that will assure, or rather will provide, good sensitivity and specificity as well as cost-effectiveness. They should be affordable, sensitive-specific, they should be user-friendly, they should be robust and rapid, they should be equipment-free, or use minimal equipment, and finally, they should be deliverable to those who need them. Thank you very much.